If we were going home next week to your breast center, and this was the case, the location must be smaller or bigger TDLUs. Now you look at the shape. And then you say that I cannot see the individual calcifications. So, are they the oyster pearl-like calcifications? Or are they big chunks of amorphous calcifications? No, they are not. They are oyster pearl-like calcifications. And look how close we are to the final diagnosis. Sclerosing adenosis is the diagnosis in 50% of cases. And grade 1 in situ carcinoma in 50% of the cases. What is sclerosing adenosis? Adenosis is the hyperplasia and hypertrophy of the TDLU. But sclerosing adenosis means that among the acinoids, this interlobular connective tissue that proliferates, which does not allow the proliferating acinus distend, so there won't be a cyst. Strangling, sclerosing adenosis. And the point is that every little finger is going to get this kind of calcification, and on the mammogram, this is the picture. The other alternative is that the TDLU gets distended and actually deformed to, let's say, the size of 4 or 5 millimeter, because cancer cells are creeping along the inside wall of the basement membrane, and they are producing fluid, and that fluid stains blue when you use the Halcyon blue staining. And within that, exactly the same type calcifications develop. So this is going to be indistinguishable from the sclerosing adenosis. Dear colleagues, you can sit there, you will never be able to make a distinction. However, you narrow down the differential diagnostic problem to 2 entities, and there is no third one. So you could ask the question by reporting the following. And the right breast, there is an area 5 centimeters deep to the nipple, and a region measures 4 by 5 centimeters, within which a large number of clusters of powdery calcifications are. Are these sclerosing adenosis with or without atypia, or grade 1 in situ? That's the report. Now what if your next case is going to look like this? And then you say, this is not in the TDLU. And poor her was about 28 years old when I took this picture. She never turned 31. She died from this DAB. Don't misunderstand me. I don't say that every DAB is killing. 30% about die from it. Now what if we are still in the TDLUs? Different case, but the location is exactly the same. More distended and distorted TDLU. And the calcifications are not the powdery, indistinguishable, but they are discernible. You never count the calcifications, but they are countable. Shape and density analysis. You say, I don't like bullet shape. I don't like spear-like calcifications that are indistinguishable, and they are localized within a distended acinus, within which there is also necrosis, and within the necrosis there is calcium, localized to a 7 millimeter area. So the malignant option in this case is grade 2 in situ carcinoma within the TDLU. But unfortunately, fibrocystic change that is born and calcifies within the TDLU may mimic this picture. Fibroadenoma does the same thing because that originates from the TDLU. Although the papilloma doesn't originate from the TDLU, but it may go through hyalinization, and within that you got the same type of crostone-like calcification. So we have 3 competing diagnoses to grade 2 in situ carcinoma. Do the core biopsy on all of them. This is a joker. You never know what you are looking at. But your next case is different. And she has this kind of calcium. And then you dress it up. And then you say, this is DAB. This was grade 2, but it was AAB. A pre-stage of a stellate lesion. A circular lesion. This is a sad story. So I really would very much like to borrow the ingenious idea of histopathology and histopathology reporting in the parotid, in the pancreas, in the prostate, and use it in the breast. We wrote a very nice article, just came out. How come that the pathologists are using a perfect terminology in the parotid and pancreas and the prostate, and unfortunately don't do the same thing in the breast? It really doesn't matter which gland are we talking about now, but this is the breast. So the little TDLU lives its normal life, and we don't know why, but one day cancer cells are produced, cancer cells are proliferating, accumulating, the long little acinus becomes short, distended, because of the accumulation of the cells. They get shorter and shorter and they disappear. And if we are lucky, we see these calcifications, either the powdery or the crushed stone-like. So this actually has a teaching point. When you have these kind of calcifications, and then you are using the larger bore needle biopsy, and you get a calcifications in the specimen, and the pathologist says grade 3, then you should think about that those cancer cells will accumulate and distend the duct, and during that time they went down to the TDLU. It's called cancerization in the lobule. And if you don't pick this up, then 2 years later she also has a DAB visible. It calcifies very soon in the TDLU. So this is a practical case. You do this and they say DCIS grade 2. No, it's not. Ask the pathologist kindly, would you mind showing me the very low magnification? Then they realize that it's actually a TDLU. If they were using this kind of histopathology, then it would be so obvious that it originates from the terminal ductal lobular units. And you ask them, why do you call it ductal carcinoma site? They shrug on the shoulder and they say, convention. I'd like to mention to you that you should fear the word ductal. Don't abuse it. And I will convince you when we talk about the long-term outcome, it's not DCIS. Anybody could be convinced that these are not in the duct. Practical example, at this time point, definitely at the magnification, you say, this isn't a TDLU. This is really a convex contour. And I see calcifications. And I want to specify the calcifications. Are these teacups? Are these like a fibroadenoma? No, they are bullet-shaped. I expect that this is malignant type calcification within the extremely distended acini. So it's an acinar adenocarcinoma of the breast. Any pathologist on this earth would call it grade 2 DCIS, but it's not correct. This is not a duct. And many times they don't even show you more than this. They show you this one because they are interested in the cells and looking at the cellular details. The site of origin is much more important from the future prediction point of view than the grade. So please ask them, would you mind giving me the lowest magnification possible? This is not a duct. Now we match the mammogram with the histology. This is not a duct. It's an acinus. And when the American Cancer Society says that DCIS means that the cancer cells are confined to the middle duct, they are wrong. So it's a very interesting phenomenon we are experiencing. That is, the first breast cancer was published 5,000 years ago. Up to 1970, nothing happened. And in the last 40 or 50 years, we are really talking about a revolution. The huge breast cancers decrease significantly. That's the prerequisite of decreasing mortality. Large cancers kill. Smaller cancers seldom kill. Baby cancers don't kill. And that's why we have to steal time from breast cancer. I'm just wondering whether anybody of you have read a book. The author is Ulson, an American author, Bathsheba's Breast. I would really strongly recommend for you to read it. It's a fascinating but very tragic description of the breast cancer in thousands of years. Bathsheba was the wife of the mighty King David. As powerful woman as any ever can be. Rich, and she died from breast cancer. Louis XIV, the King of France, powerful, his mother got the nun's disease. She was brought up among nuns, and she experienced that quite many nuns got breast cancer. There are so many nuns even today with breast cancer. I would very much like you to read the book, but at the end you are getting disappointed because early detection is not mentioned in a proper way. The no change for 5,000 years was replaced with the revolution you and I are causing, and it's called early detection. It's not chemotherapy that is a solution. It's not new therapeutic regimens, because those patients who are coming with advanced cancer are going to die from breast cancer in a very high rate. So therapy changed. Surgical therapy changed. Oncologic therapy changed. Did histopathology change? I'm so disappointed to tell you that it didn't change much. And I'm going to express my enormous disappointment in the colleagues, the pathologists. And I really want to convince you that you should never, ever use the word DCIS after this lecture. A friend of mine, a brilliant MR expert, Steve Harms from Arkansas, came once to my courses. He was a faculty member, and he felt so sorry about me because I felt frustrated. And he gave me a present. And the present was one of Dr. Seuss's books, Too Many Daves. Did I ever tell you that Mrs. McCabe had 23 sons and she named them all Dave? Now, obviously, it wasn't a smart thing to do. Why? Because she wants to talk with this little Dave or that one. Please come into the house. She doesn't get one. She gets 23 on the run. And it really caused a lot of trouble in the house. And so now she starts to think about, why didn't I call them A and B and C and D? But she didn't. And she believes that it's too late now. I was very surprised how much I wished this book to kill the word DCIS. And I rewrote the book. Dear colleagues, did I ever tell you that Dr. Breast pathologist had 12 sons? And she named them all DCIS. This son is very different. It's called intracystic papillary carcinoma, DCIS. From this one that is not even visible on the mammogram, but visible on MR and galatography. And this one is architectural distortion. And this one is architectural distortion of different type. And this is calcification. And this one is a different type calcium. And this one is dotted casting type calcium. And this is casting type calcium. And I could go on and on and on, up to 12 different presentations of DCIS on the mammogram. Now, I tell you, it wasn't a smart thing to do. Ladies, can you imagine having 12 children? You got goosebumps just from that question. What if you were very smart and gave the same name to all of them? If and when Dr. Breast pathologist wants to call this specific DCIS, let's call it crust stone-like calcification, not the casting, into the house, that is, to the tumor board, she doesn't get 1, but 12 come on the run. And I hope that they start to think, why didn't I call it grade 1 in situ within the TDLU? And grade 2 in situ within the TDLU. And grade 3 within the duct. And intracystic papillary carcinoma. But they didn't. And they are not willing to do either. But I will never give up, because it's never too late. We have to wait for an entirely new generation of pathologists who are going to be influenced by you and me, because the current generation is very difficult to influence. I only beg for dropping the letter D. So please, tell me that it's in situ. You are the expert of saying that. Tell me the grade. You are the expert saying the grade. But please satisfy my request. What is the location? Because as soon as a path report would read as follows: unifocal, grade 2, carcinoma in situ within the TDLU, I would immediately connect. I would immediately understand what they say. But if I'm seeing a cluster and they call it duct, I'm confused. If they were telling me in the path report, grade 1 in situ within the TDLU, I would immediately understand what they say. Grade 3 within the ducts, I would understand. You may experience this as too harsh, but I'd like to tell you, in the future after this lecture, whenever you utter the word DCIS, please feel bad, because you're not communicating. Why do we open our mouths when we don't communicate? And I can go as far as that. When you say DCIS, either you don't want to communicate, which is not very nice, or you don't even know what you're talking about. It's an outdated term, especially today when we have modern imaging and histologic techniques.